Maybe as we're gathering, I'm just going to go through folks who are on the phone. I have a 206-520 number. Can you tell me who you are?
Robin DeForest, CWP.
Hi, Robin. Thanks for joining.
Okay.
We have a 206-757 number. Who is that? If you're a 206-757-8238, can you please unmute your mic and tell me who you are? Okay, let's try 206-783. 783-1763. Can you tell me who you are?
This is Gwen O'Keefe. I run Go Healthcare Strategy Consulting, and I'm a physician.
Hi, Gwen. Thanks for joining.
Hi. Thanks.
Yeah, and then we have a 206-963 number. 963-1605. Please tell me who you are. Okay.
Sorry, it took me a minute. This is Cara. I'm actually on my way. I'll be there in just a minute.
Okay. So, Cara, just come up to the third floor of the rotunda, and you'll need to get past the big burly guys at the door.
Okay.
Make sure you leave your weapon at the door too.
Okay. Shoot. I guess maybe that's the wrong word to use.
She's a nurse. She has the needle. Great. We're still kind of getting gathered here, so I just want to see who else is on the phone. If you haven't let me know who you are and you're on the phone, please unmute your mic and tell me who you are.
This is Francis Shaw from Molina. Good afternoon.
Hi, Francis. Thanks for calling in. Who else is on the phone?
This is Dr. Dave Luxton. I'm with PSHS, Office of Forensic Mental Health Services.
Hi, Dave. Thanks for joining. If you're here in Olympia, we're in the Capitol, and you can join us in person.
I am almost there, actually. Thanks.
Okay, good. We'll see you soon. Anyone else on the phone?
This is Adam Romney. I'm on the phone as well.
Thank you, Adam. Other people on video or on phone?
Micah Matthews, Medical Commission.
Hi, Micah. Thanks for joining. Great to have you. Anyone else? Okay. Well, good. I think what we'll do, since it's a little bit five minutes after, maybe we'll call the meeting to order. And just for purposes of everyone who's on the phone, we're just going to go around the room and let everyone else who's on the phone call know who's joining here in person. Chris, you want to get things started?
Yeah, sure. Hi, good afternoon. Chris Cable with, I guess I'm a little unclear. Technically, officially on my brand, Group Health, but legally, Kaiser Permanente, Washington.
That's a change.
Yeah, sort of. In 30 more days, I'll have a better answer.
Senator Cleveland.
Good afternoon. I'm Senator Annette Cleveland. I represent the 49th Legislative District in Vancouver, and I serve as ranking member on the Senate Healthcare Committee.
Good afternoon. Chief Medical Officer, CMO Community Health Centers.
Sheila Granger, representing the Washington State Health Information Management Association, and also with the Commission. My name is Lisa Roche, Providence Health and Services, and telehealth after I'm coding.
Oh, great. Great to have you. Thanks.
Senator Randy Becker, 2nd Legislative District, Mount Rainier. I'm Vice Chair on Healthcare and Cost Share.
Hi, Brody DeCinto. I'm the General Manager over the convenient care efforts at Cambria Health Solutions and Regents as well.
And this is John Scott, a Medical Director for Telehealth Services at University of Washington. For folks in the room, your only microphone is right in front of me. So it's a very good microphone, but you do need to look at it when you're speaking. So just a reminder. And if folks are on the phone or on the call, can't hear us, please just let us know, and I can repeat the question or repeat the comment. But I think this is one of our best AV setups. So I want to thank Senator Becker and Senator Cleveland for the guys who all helped get this set up.
We want to thank you for coming down here at this time of year. Thank you.
So it's a pleasure. So I think the first order of business is to review the minutes from last time, and so I'm going to pull those up and display them. But for the folks who are here, I think those were printed out. Let's just share my screen. There was quite a bit of back and forth last time, and I did offline. I did have Cheryl, Chris, and Brody take a fine-tooth comb to those comments, and so just so folks know that they did have a extra opportunity to kind of go through things. I think there's a lot of discussion about payment and which codes to use, and I think that's still being settled. It's probably a fair assessment with lots of action items that we'll try to get to are in there. So let's have folks take a look through this and see if there's any corrections or things that were left out. And maybe as you're doing that, I do want you to be thinking about the format of our notes. They're currently in an outline format. And I just want to see if that's good for people, or if you want it more in a paragraph narrative section, I can do that. I think because there's a lot of back and forth, some comments, we have kind of put them more as standalone comments. So if people feel strongly, we can definitely change them. Okay. Right. Brody, are you seeing anything? Or Cheryl, there was quite a bit of back and forth. I just so you know, I pretty much just copy and pasted what you guys had sent me in terms of clarifications.
Yeah, if you want us to look through it with a finer tooth comb, we could, but we're fine with what we submitted.
Okay. Same here. Okay. Good. Well, unless there's any last comments, maybe then we'll say that the minutes are accepted. Does anyone disagree? Good. All right. Well, we'll have those minutes released to the public. So the next thing we're going to do is we have a logo to decide upon. So Brody has very nicely led that effort. And I'm going to be pulling up the two options that people have voted on, and we have two finalists.
That's the logo right there.
Oh, yeah, you like that exploding? Right. So let's see here. What's it called again?
Oh no, I'm lying to you. Let's see this.
Oh, yeah, sorry. It's on my desktop. It's right here. There we go. I'm having a problem opening this. It says it's doesn't recognize it's a PDF.
Do you guys want to come around and sit here so you can see the screen?
You guys can see that.
Oh, I see you're looking at a little, okay.
Shoot.
So then that was my seat before, and that's what I would do.
Oh, that's a great idea. I don't want to turn my back on.
Exactly.
Would you like the
Yeah. Sorry, I'm gonna have to pull it up through my email. But maybe what I can do is, Brody, I can turn it over to you, and if you want to just talk us through the two formats. I think these were emailed to folks, and you can even show them if you have them printed out. There are two versions.
Okay, well, there were essentially two different sets of logo styles that people generally bubbled to the top. One of them was more of just the words in a kind of a horizontal format, and the other one was more of like a official seal. And so both of those were what the team put some color around and some concepts. And so the general feedback about some of the logos that were put into both was there was some feedback that said that they generally like the idea of a smaller version of the logo that could be used for like a Twitter handle or any other use that doesn't really require a lot of space. Or as you scroll down the screen, you don't want this big logo to continue with you, and then it kind of shrinks to the top as you scroll down. And so that type of approach and style was applied to both of those logos. So it's probably no surprise to anyone here that the logo is generally green in color. And there's a couple of reasons for that. I mean, one, we're in the evergreen state, but also none of the actual participants in the collaborative actually have a predominantly green logo. I mean, evergreen potentially, but it's most logos were kind of in the blue realm, and so the thought was, let's pick something that is as neutral as possible, where it's not really copying any of the color schemes of any of the participants, but also kind of represents the green of the state. And so what you're seeing on the screen right now is the one that I think was actually the most popular across, which is just a very basic logo, but there is some subtle aspects to it where you can see that the G and the T in Washington and the T and the H in telehealth are touching, which is highlighting the connections that happen in telehealth. And so it's kind of more of a connections aspect to it. And on the bottom left, you can see that if you wanted to make that the logo of what the screen shows as you scroll down, or a Twitter handle, you can see that there's a much smaller version of that logo as you go there. So the following pages kind of show what the example would look like if it was on the Washington State Hospital Association page. You could see that a blue logo, as you can see at the top, but the Telehealth Collaborative logo shows there, and it's kind of being blocked by by Dr. Scott's video version of the face, but you can see what it would look like on a Twitter feed or letterhead on the right side underneath there as well.
It's very professional.
And then if we go to the second one, this was the more of the seal. It was deemed as more of an official kind of look, but what was kind of interesting is that most people were drawn to, there were two types of fonts. One of them was more of a classic, really official looking, and one was kind of more of a modern font. Even though people like the official aspect of it, people seem to lean more toward the modern font, and that's why what you're seeing here is different color palettes of this. You can see it's more of a teal type of green, but it's still within the green family. It is slightly different than the one before. And if you scroll down a little bit more, you'll see now the little Twitter handle is more of a kind of a circular WSTC down there, and then we can see what it looks like on the screen. So here you can see it takes a lot more real estate, right? And my personal opinion is it looks a little less like a logo, and it looks more like something you're just putting on the page, but that's what it would look like there. And you can see what the Twitter feed would look like on the top right, and then the letterhead on the left. But it is a much more real estate hungry logo. And so that's generally kind of what we came back with as far as the two top options that came back from the group.
Great. Thank you so much for doing that. I see if there's questions or comments from folks here about the various
I have to
logos.
say, I really like that top one.
The first one?
Yeah,
Okay.
I just think it's clean. It says what it needs to say, and it
There's a subtle connection there that you can point that out to people. Hey, look at the connections that are forming between some of the letters.
Looks like the T and the I also are
T and I.
connected there. Right there. Yeah.
Just
and where you used it with that picture, it really
pops out.
Yeah.
That's just my thoughts on it.
And Brody, I mean, would there be any differences in prices, or like if you put it on a letterhead? I'm just thinking of.
Yeah, all these fonts that you see here are within our library, so there would be no charge for the. So they're both free logos.
Other questions or comments? Well, are we ready to vote? Okay. So what we're going to do is we're going to vote in this room first, and then we'll kind of do a roll call for folks on the phone, and just so everyone has a last view. This is option one, where it's mainly just the words with some of the words connecting, the G and the T, the H and the T, and the T and the I. And then the option two is more of the stamp. It looks like a Maybe something that's on the back of your your driver's license or something like that. Yeah, good for a T-shirt, exactly.
I was thinking of content.
Good. Well, so let's just see who's in favor of option 1. Just raise a hand. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have 9, and option 2. Anyone for option 2? Okay. So we're going to go to the phone, and if you can please just announce yourself, and if you're voting for option 1, just unmute yourself and say you'd like to vote for it.
This is Cheryl. Go ahead.
Scott Kennedy votes for option 1.
Thank you, Scott.
Thank you.
Cheryl Huchalla votes for option 1.
Okay.
Maggie McGinnis, option 1.
Francis Goff, option 1.
Lori Wakashige, option 1.
I think we might have a final vote here. Anyone else who wants to vote on the phone who's part of the collaborative?
Jeff Jones, option 1.
Thanks, Jeff. Jeff Jones is on the phone. Anyone else? Okay, I think we've got almost a near unanimous vote. Yeah, all right, I love that. Good. Good. Well, good. So thanks, Brody. So maybe what we can do from a practical standpoint, we'll need that the
IRES.
Yeah, and then we'll pass it on to Wisha to put it on the website. I really appreciate.
Well, if you want it embedded in like I don't know, are they designing the photo equivalent of what that page would look like as well, or?
They can if we ask them.
Yeah.
But they will. The deal of getting a free website from our good friends at Wisha is that they're keeping in all of their
branding.
Yeah,
I mean,
branding.
so we show what it looks like with their branding on the screen right now. So.
And then just real quick to add, Dr. Scott, I don't know if you're going to touch on this, but the addition that we made this week to the.
Yeah, I was going to pull that up. Thank you, Ian. So let me just.
Yeah, the info already, and then see what they want to do.
Okay.
So we've added quite a bit of resources to the Wisha website, and so I just wanted to show that to folks. So this has the vision and mission statement, of course, but then there's quite a bit more under resources here. So I'm just pulling that up. So we grouped it into as, there's lots of telehealth organizations out there that could potentially be very beneficial for folks who have questions, starting with Wisha, who's hosting us. So we got to get them first. The Association of Washington Public Hospital Districts, the American Telemedicine Association, the Northwest Regional Telehealth Resource Center, which I do want to remind folks is having their annual conference in April in Seattle. And Carla is involved with that if you have any questions. And then some of our neighbors, there's the Idaho Telehealth Alliance and the Telehealth Alliance of Oregon. Lori reminded me that the Telehealth Alliance of Oregon is having their annual conference in the next month or so. So that's a great resource. There are some federal telehealth resource centers that have lots of great information, AHRQ, and Tetric, CTEL. So there's a lot here. And then as you scroll down, there are some funding agencies. So if people are interested in writing grants, I would say that HRSA has probably been one of the biggest funders, and that would be under the federal telemedicine grant programs. Believe it or not, USDA and the Federal Trade Commission have also been great resources for funding. And then these are some of the journals if people are interested in reading more of the academic publications. Some of these are more trade journals. And then I think the thing that's probably the most helpful for folks are these new telehealth tools that have been added For example, the Centers for Medicare and Medicaid Services telehealth fact sheet. So I'm just going to pull that up. This is it has a lot of information on like how you would bill, information on what CPT codes are there. So this is just a real treasure trove of information. Let's see, if you want to know is your district rural or not, you can click on this thing. So Senator Becker, I'm going to type in your zip code. See if,
328.
okay, it's a 98.
328.
328. So we can search. And I think we'd have to have your address and everything like that, but yeah.
See what it says.
Yeah, okay, right. There we go.
Okay, 44106, 14th Avenue East. Of course, Eatonville.
Okay, so let's search.
It's a gated community, I'm fine, you guys.
All right. Let's see here. What's going on?
The internet's pretty slow.
Oh, yeah, it's slow. Sorry. If you wanted to get covered through Medicare, I guess you're still considered in a more urban area. Yeah, it's hard to believe. Huh?
Really?
Yeah.
Wow.
Yeah, so there's
That's
two things with Medicare. One is are you rural, and another is if it's a health professional shortage area. When we looked across Washington State, 20% of all of Washington zip codes are considered to be rural.
So that's really interesting because we have one doctor and 2 PAs within probably 20 miles of us.
So their
definition is really.
It's very strict, yeah. And it's actually where you are located at the time of the consult. So if, for example, you had an issue and your home address was rural, but you went to, the nearest hospital, if that hospital is now considered urban, it wouldn't qualify.
Okay.
So I think it's just a helpful exercise to show for Medicare, it's really hard to get paid.
Yeah.
These are some of the state telehealth Medicaid reimbursement policies all across the country. So all 50 states. There's some information on the interstate telehealth licensure, the role of telepresenters, the California Telehealth Resource Center. So a lot has really been updated. I would encourage you to look at this. I want to thank Denny and Joelle in particular. You sent me a lot of these. And please, if there's anyone in the collaborative here who knows of some other great resources, please let me know, and I'll check them out. We'll do some vetting, but we really want this to be one-stop shopping for folks who are just trying to get involved in this. So again, thanks to Wisha and Ian for helping out with that.
Yeah. So more importantly, I knew that Cara first, or she started with the initial list of resources, and then Denny did a ton of work to add to it and come up with this list. And then I thought this over, and I was really interested in getting the information to Wisha. But Angelica, which is the one who then created the site or that subpage and how it looks, and so I think that's a great repository that we now have on the collaborative website that we can send out to people.
So the next thing I wanted to do is get to some of the homework assignments that I think we had. We wanted to create a frequently asked question document, one which is focused on clinicians and one which is focused on for patients. So this first one is something that Julie Sylvester and I looked at and took a crack at. And we really started out really basic, like what is telehealth and what's the difference between telehealth and telemedicine. I just quoted straight from HRSA on this. And Julie Sylvester, if you're on the phone, you have some comments here. I don't know if you wanted to speak up and say something about that first point. Julie, do we have you on the call? If not, I can read what she had said. She just wanted to say that telehealth can accompany, can include like store and forward or asynchronous technology, and that there should be some distinguishing features between the originating and the distant site. I didn't want to go into too much detail there, so I don't know if that's too confusing for folks. Anyone feel strongly about that? All right, Denny, do you like it as is, or do you want more detail? Yeah. My hope was to keep this at 2 pages. You know, just be a quick kind of overview.
The only thing to call out is that the answer to this one is different than the answer on the other one. The other one says there's no difference, and this one says, it just says they're used interchangeably. So you might want to tie them together to say, like, even in the answer for first, you say, however, they typically are used interchangeably or something.
Or in practical uses or something like that, they are. Yeah. Thank you for picking up on that. Okay.
Also, I'm not sure if this is our own convention, but telehealth, at least within group health, refers to the Medicare principles that you just pointed to, because I think that's what Medicare, that's the term they've landed on. And so I don't know if we should call that out here, that if you're thinking about Medicare criteria, telehealth is specifically the benefit that they refer to.
Okay. The benefits. I'll word sleuth that a little bit.
Yeah.
Any other comments on that first point? All right, and the next one, we kind of dive right into, can clinicians get paid for telemedicine? And this is where I just really copied the bill, 5175. So hopefully there's no controversy there. And then I did call out that Medicare does have some different criteria. It has to be live, interactive video. They have to be in one of the facilities listed above, and then they need to be in a rural area. And this is where we refer them back to that HRSA tool. Any comments or suggestions on that section? And, you know, just to orient us as to who would be reading this, and I'm really envisioning maybe a doctor in a small practice who doesn't have someone like Danny or Cara who can call up. I'm really thinking of a small practice who's trying to look into this. So
would you be able to, I know you want to keep this general, but if it's a doctor in practice, would you want to maybe provide a link for the more details of some of these?
Yeah, there's a couple ways you can do that. I mean, you can have links out to other things, or you can have kind of like an accordion, where it can, can give you a general response and then say, for more information, and it'll kind of roll it back down. So there's 2 ways you can do that. We can certainly do that.
I'm just thinking of the physicians that I used to work with who want to get in and get out of there to get the information they want and get back out. If you're using that way, or just are you envisioning this as the doc has extra time and they're going to sit down and read this and figure out where to go? Yeah, I mean, I think that we really want to get them their quick and dirty kind of questions. I mean, I envision someone reading this for like 10 minutes and then they can dive in with their team and the details. And I'm envisioning it where you have that ability, but you walk out to your biller in a smaller office and say, you need to look at this, and here, it includes the links. I think we can certainly put the links. We've got them on the website there.
Putting a link to the NRTFC where they can answer questions.
Yeah. Okay. So maybe I'll put it at the end here. For more detailed information, please see the NRTRC. I think the NRTRC and the ATA websites are really good. Cara, what do you think?
I was just thinking that when you were showing earlier the website and the link to this MS the telehealth facts or something, I really like the format of that. It's so easy to just go to and find the question and So rather than a sort of a narrative thing, so I'm just thinking format-wise and easy glance to find this information.
Okay. Other suggestions in the collaborative? Anyone on the phone? Hopefully you can see my screen. You're following along. Okay, well then maybe we'll go to the third question, which is, I get this a lot, is what technology do I need in order to conduct a telemedicine visit? And I don't endorse any particular equipment. I just say these are the kind of the principles that it needs to be secure and encrypted, and it needs to meet both the HIPAA and the high-tech standards. And then they should have a stable internet connection, which allows for audio and video. I know in the past that sometimes ATA has been very prescriptive, like 1 megabit per second of upload speed and things like that. I didn't put that in there, Denny. I don't know. What do you think? You can get it in infinitesimal detail. Yeah. Okay.
Well, this is Maggie on the phone. Do you need to make some sort of reference to some sort of permanent record of this teleconferencing visit?
Maggie, if your question is, do we record these video consultations?
Or should they be recorded?
That's a great question. We do not. Just like we don't record in-person visits. Just because that's a similar standard, and also from an IT security standpoint, it's very difficult to make sure that that is super secure. So I know just when I talk to our internal IT people, they say, please don't record these. And I'm getting
how is the visit documented?
It's documented as any other visit would be. So you would have maybe I'm an infectious disease doctor. I'd say outpatient telemedicine infectious disease note, and I would say, this is Mrs. Jones, 65-year-old woman with osteomyelitis. They have a standard visit, and then there's a one-liner that says, this visit was conducted via live face-to-face secure connection, right? That's kind of the phrasing we use.
If the point that she's asking to make is to add another Q&A in here, maybe right after the consent.
Yeah.
Is there any difference in the documentation that I need to provide for a clinical telemedicine visit versus an in-person visit? The answer is no. The exact same standards apply.
So how?
Might add that language that this visit was done.
Yep. How do I document a telemedicine visit? Yeah. The answer is you document.
If you're putting it right after the paragraph that clearly outlines some documentation needs to exist, that.
Yeah, this is right after the consent area.
Yeah,
that's a great
then
point.
you're already kind of leaping off of that.
As you would for any other counter, you need to add a comment that this visit was conducted via live face-to-face video conferencing link. I like that. So what you use, Denny? This visit was conducted via live face-to-face video teleconferencing.
Robin's on the phone, I probably can tell you more about this, but I think for billing purposes, we also have to note where the patient was located. We came up with some language.
Okay. Tonight, so Robin DeForest, just to tee up a question for you is, when we're documenting a telemedicine visit, is it imperative that we also say where the doctor was and where the patient was? We have a billing expert from Swedish Providence that we're going to ask first. Maybe if I can put you on the spot. Yeah, can I put you on the spot? Do you need to document where the patient and the doctor are at the time of the visit?
I don't think it's as necessary as for the distance site providers, but the originating site of the patient, I think it would be very helpful to be able to know.
Especially for Medicare. Also necessary to document where the patient was at the time of the visit. I mean, that's going to be relevant when we start talking about home and things like that, right? Robin, are you following along with us and seeing what I'm writing?
I actually don't have access to your screen right now, but in hearing what she said, the only thing that we asked also is to document the address from an auditing perspective. If we were to bill Medicare, we need the physical address so that, because normally the patient's location wouldn't be in our EMR. And by adding that GT modifier, we are verifying that the patient is in an approved location, and we have no way of proving that. So to bill Medicare, we would somehow need a way to verify that rural location of the patient.
Patient's physical address. Okay, thank you, Robin. Okay. All right, maybe we can skip back up. There was a question about what technology do I need. Do you think it's necessary to say you should not record it? Or it's not necessary? It's not recording of the visit is not necessary. Okay. And Micah, you'll be happy to see that we have called out in particular the MQAC document, requirements, that if you're a physician providing that, you need to be in compliance with the MQAC guidelines on telemedicine, and that's part of this visit with the technology.
Thank you. That's much appreciated. It looks great through the telephone.
Okay. Okay. So the next question is, do I need a special? Yeah, sure.
So the other thing I thought about with that question, it was very focused on the video part, and so for store and forward, it made me wonder what technology or requirements are around that, or if that's even worth another question saying.
Yeah.
Can you just lump it in to say and other appropriate store and forward methodologies?
Oh, yeah. For me, I suspect store and forward is less about the technology and more about the content.
Right.
How much needs to be in there for it to be allowable? Is it the entire EMR and everything associated with the patient, or is it sort of a clinical encapsulation? Or I know email is specifically excluded, but between email and store and forward, there's a lot of gray.
And you get into some legalese with transmission, storage.
And that, right. Right.
I think this, yeah, we might either have to have a separate section on that, or I think it might get too confusing in the technology area. Yeah, no, I think it's a great question. It's just kind of, it can get super complex. The next question I wanted to attack.
Before you, just to point out, I don't know what it is, but your link is missing some letters. I'm sure at least an H. HTTP. Just make sure your link is
valid.
Yeah.
Yeah. That's great. Thanks, Brody. Any other comments before we move on to the consent form question? Yes.
I'm Dr. Dave Watson. I'm with the SHS Office of Personal Health Services. I called it, also affiliated with the University of Washington. My recommendation includes something about safety protocols. This is something that's often overlooked. Healthcare providers providing services to some of the folks. What happens if a person says they're going to harm themselves or they have a heart attack? Why? You need to have a protocol in place to address that.
Great point. Thank you. That you have safety protocols in case the patient is in danger, i.e., crushing, a heart attack, suicidality, or severe respiratory distress, etc. How's that? It's also recommended. Okay. So next I wanted to talk about the consent form issue. And I pretty much just copied and pasted this from our collaborative report. So there should be nothing new here. But just to review that we do not say that a special consent form is necessary. However, a general consent form is necessary. And that the things that are important are that the patients know about the technologies, the capabilities and limitations, and that they're agreeing to do that. And they should also know the credentials of the practitioner. So remember the whole showing your badge, so they know that you really are who you say you are. And I hope it's okay with Denny and others who gave examples, but I just lifted it straight from what you guys had given us, and it's in quotations. I didn't identify you, but did have this example here because I thought it was very concise and easily copied into a macro for people's EMRs.
Because that code is so long and it doesn't fit quite the formatting, maybe we should just italicize that paragraph to specifically call out that it's all one.
Adam, do you have any other comments about this section about consent forms?
Not for me, no.
Okay. Thank you. We just went over this area of documenting the telemedicine.
I have one more question. So I'm very focused on Store and Forward because that's largely what we do at Group Health or Kaiser Permanente. And so I think this consent is, again, geared a lot towards a video interaction. So, for example, with Store and Forward, there's not necessarily an opportunity to review with the patient ahead of time because the patient, at least next year, may initiate these from their own home as they wish. And so I'm just thinking about this form. It may suffice for this year, but at least next year we may think about adjusting it, realizing patients can initiate visits from their own home, and a lot of these things won't be achievable as the best practice.
So I'm just going to add a little phrase here. The following is an example that could be included in telemedicine as a note, which is particularly focused on a face-to-face video visit. Okay. Thank you. This is the section where we talk about how do you document. And then the next question is, how do I bill? And I put to be determined because I don't think I have that answer yet. If anyone wants to help me with that.
Have a billing specialist.
Yeah.
For you.
Did you know, actually there were a couple of great resources that Joelle Buffy had sent to me that I think are on our overall resource list.
Yeah. CMS actually.
Yeah, we could refer.
May I go back to your second question when you talked about how to bill? Can clinicians get paid for delivering telemedicine? And maybe I'm missing it in here. I know you took it right out of the bill, but I think that along with although there are certain restrictions, I think that it should actually at some point in here say about contacting your carrier. So you can verify before you deliver the services, whether that service would be covered.
Okay.
I almost feel like the answer should be yes and no, depending on the scenario.
Yes.
Because there's just too many variables to say
yes
yes or no.
We can say, in general, yes. Look at that.
For doctor-to-doctor visit or from doctor-to-home visit?
Doctor-to-doctor as well as billing.
We define what are we referring to, like in this document. Yeah, that's a good point. So that people who aren't familiar with the language, they can understand what we mean when we say distance.
Cheryl, did you want to say something?
So I think it's fine to contact the carrier, or there's multiple ways they can verify benefits. I wasn't sure if this was all benefit discussion or billing as well. So if we're talking about coverage, I guess you can refer them back to the health plan. For reimbursement, I was thinking you could refer them back to the payment policy.
Okay.
which I think was the other section you were in.
Yeah.
Should we also say in here that, like services are medically necessary and covered by your insurance? You know,
Well, because we create a parity, if that parity passes, that's the one caveat.
This is for practitioners, and we have a totally different. Ah, yes, thank you. Thank you.
Instead of saying the patient.
Yeah.
Checking the patient's
Yep.
carrier or something.
Yep. Recommend that patients contact her.
Even the title of what we should probably
Yeah.
be better
I
accessible
forgot to use
for
the
the
title, we
audience,
say frequently asked questions about the
for providers, for clinicians.
Okay. Thank you. Thank you, Ricardo.
Definitely, if
And
this
then-
is if the I definitely understand that the insurance aspect is the most complicated part of this, but if this is going to doctors and to consumers, I mean, a lot of people just pay for it. Even University of Washington right now doesn't use insurance in your telehealth piece, so there's a lot of focus on, like, the question as it states is, do you get paid? And the answer is yes and no in some cases, but yes, sometimes just through cash. And so I'm not sure how
So maybe there should be, you know, if the patient, or if the patient's insurance doesn't provide coverage for telemedicine services, the patient has the ability to, or you have the ability to offer services through a cash payment.
Well, and what I'm saying is some doctors choose not to even work through insurance. So it's not even a question of whether it's covered or not.
Right.
There are instances where cash is all that the doctor accepts. So
So I think from a provider lens, we've almost split out this to like 3 different questions. Is, can I bill for it? What's the likelihood it'll get reimbursed by any payer? There's the third one I came up with that I already forgot. Oh, and can I just bill cash pay, or you know, can I just deliver this
Depends on your
service?
contract, if you're contracted to you.
Cash.
But I'm not sure how, I mean, I think already you're getting into 3 pages now.
Yeah, I know. I know. Yeah.
Well, I think we have to be really careful with the cash payment. If it's a contracted provider, it's a covered service, it needs to be billed.
Yeah.
Yeah. Certainly cannot do that with Medicare.
Well, maybe we can just ignore that part of it, but the other 2. So can you bill for it, and what's the general on the reimbursement side?
It varies exactly what it is. Depends on the service you're rendering, who the patient, you know, demographics, and set they're just going to do their due diligence prior to starting.
Yeah.
So John, maybe to simplify it, it's actually starting back with the question. So maybe the question should be, can clinicians bill insurance companies for telemedicine?
Yes.
And then your answer is now aligned.
So, okay.
Because they get the world out of pocket or cash payments, that's a whole different category.
And then where it says review your payment policy, it would be the patient's healthcare, right? I mean, I don't,
Thank you. What do you call that, Cheryl? What's it called? The patient's coverage policy?
well, so I think if you're talking about coverage here, it would be their benefit policy.
if it's how to bill, then it's the health plan's reimbursement policy.
Right.
Maybe that's the language we need to use then. So if I've got 8 different insurers I'm trying to look at, I'm at least looking up the right title of the form.
So the CMS fact sheet and then the individual.
Yeah, we can all provide you, we already have the links to the reimbursement policy. I think it's best to refer to the online policy than it is to answer it hard copy on here, because things get reviewed all the time.
So maybe something check online for the payers, whatever the quote is.
I think if you get too much in here, though, it really boils back down to the provider's office taking the time
Oh, they're gonna be having to take it.
Yeah.
Yeah.
We recommend you check.
Check every box.
But at least we can steer them, right? I mean, the whole purpose of this is to give them a big picture view and then steer them, so they don't have to do the hunting themselves.
I see this as the hook. I hear this telemedicine something.
Mhm.
Okay, let me go look it up as a primary care doctor.
Yeah.
Is there at least one sheet I can look at to say, is it worth me looking into this anymore or not?
Yeah.
And that's what I see this as being.
Exactly.
Yes, it's worth looking into, or never mind, I'm not gonna waste my time.
Are you envisioning, and I'm sorry, I'm kind of getting out of biting, are you envisioning that they will be able to ask questions, and as they have questions, it could be added to this?
Good question. You know, I can tell you what the NRTRC and ATA does is sometimes they have ongoing chat boxes and things like that where there can be a kind of just ask the expert and they're public. You can view them, so you can be part of a listserv. That might be.
CTEL policy says enough about reimbursement, or is that a start? We're going to steer back towards the social questions.
Yeah, it's a good start, but digging into the details might be more question and answers, yeah.
So I don't know if you guys could hear what Cara and Danny were talking about, but they were saying that CTEL, or the Center for Telemedicine and E-Law, is that what it is? They have a pretty good resource to get people going. I'll tell you what, maybe what I'll do is, I think we got a pretty good start on this. I'm going to send it around for people to look at again, because I think everyone's going to have maybe a couple other comments to make about this. I wanted to move on to the patient-facing one that
I think I know you're multitasking. I don't think you finished modifying the question. With health insurance.
This one right here. Yeah. How do I bill for telemedicine?
They were saying bill insurance carriers.
Okay.
Was
bill insurance.
Just discuss it. Make it easier.
Carriers. Thanks. Yep. Right. I'm going to save this. I know it still needs a little bit more work, but maybe we can continue some of that offline. And I wanted to give Sheila an opportunity to present what she had come up with. And Sheila, I think a lot of this was straight from the ATA website. Is that right?
It is. Okay. So when I started researching, Q&As for patients on telemedicine, there's a lot of redundancies out there, and then I came across the American Telemedicine Association. So basically, what you have in front of you is pretty much the Q&A directly from that website. I changed some of the verbiage on there, not to distract from them getting the credit for it, but just make it a little bit easier to read and to understand. So I wasn't really sure how we wanted to do this, if we're going to have like our own, or since on the Washington State Hospital Association, we have a link to the ATA. Do we want to call out, the link to the Q&A, because they have a special section within the ATA for the Q&A. So anyway, I just wanted to present this rather than create something, rework something that I don't think we need to, because there's a good tool out there.
Yeah, I guess the only question I have is, Sheila, is if this is pretty much copied straight from there, do we need to acknowledge them, or do we need to get permission from them?
Yeah, and that's what I was going to do, but I wanted to see what this group thought first, because I'd be happy to reach out to them, because it's copyrighted, but reach out to them.
I haven't seen the original, but I read this and I thought it was very well done, very easy to understand.
One thing I'm always cognizant of is making sure it's written at a 6th grade level.
That's why I choose them.
It would be nice to have them in similar formats, position.
Same font and all that. I can fix that.
I just want to get my whole assignment in on time.
Yeah, she did. She was a week early. Thank you for doing that. And this is, Sheila, this is like 2 pages. Something.
Right.
Okay.
And then I thought what we could do is I put the link to the ATA if they wanted more information, you could also put the link to the Washington State Hospital Association, depending on how much interest people have in what they really want to learn about.
Well, this is going to be on the Washington State. This is going to be on the official website, yeah. So they would have had to come through that.
Is there anything in this that needs to be more specific to Washington? Is there, I don't know the answer. There may be nothing significant, but if we're going to basically adopt the ATA,
yeah.
If we're going to have a separate one our own, but even kind of copy some of theirs.
So on the second page of Medicaid, there is a link to each state for their gap analysis and their coverage and reimbursement, and Washington's actually listed on that. So I think you're looking for something different, but I did go look at that and make sure Washington is there.
But I think Julia, you raise a good point, is maybe having a little bit more specificity under Medicaid and the private insurance, and just maybe explaining a little bit of Senate Bill 5175. Because the worst thing is when patients get their hopes up for this, and then whatever reason it's not a covered benefit, or they think that crushing chest pain is a good idea for telling
Or maybe
them.
even on the Medicaid part, maybe we focus on just put the information in there for Washington, and then just have the link for if you want to check other states, here you go. But I'm just thinking, if we're going to do our own document, maybe we just need to be more focused on the Washington interpretation, since that's the majority of patients that would go to the Washington State Hospital Association and look at our resource.
Information vis-a-vis.
Privacy in Washington, you need to be licensed and credentialed.
But that's back to the for the clinicians, right? Or is this is for patients?
This one's for patients.
Okay. But that's a good point. We want to have something about licensure and the.
As well as the second question is that physicians get paid for what should be issues that are paid.
So I'm gonna put down here.
Is there any specific regulatory that needs to go for these services?
I think that, I don't think there's any special licensing requirement to do telemedicine, but I do think that as we've talked about, in my vision anyway, is that center of excellence where they come through and actually maybe get a certification or something stating that they've gone through and they understand. And I'm more worried about mental health than I am the rest.
That's an intriguing proposition to be sort of like, if you will, like an addict skill or advocacy.
Yeah.
Is that, I wonder if that was the purpose of that.
I want to call out Francis Goff, because this is something that Francis and I have talked about the need to having certification. Francis, you and I've chatted about that. Do you want to say a little bit more about having some kind of a certifying body of doctors? I don't know if I lost you. Anyways, maybe I had to sign off, but this is something that Francis is certainly interested in. And she helped write ATA guidelines, and is down in Molina, so
Well, my question is then, and Alicia, you might, is that something that we would, because we've defined home, now we're asking for parity, would we have to say and define who could bill, or leave it open at this point and then bring it back next year with a program?
Maybe leave it open right now.
So I do think we have to think about that.
I think but one suggestion would be either that the regional commission should be, which would be at the home. I mean, things that we have at the regional level versus the center. And in this case, Simon would be a credit, and that's what we do for building purposes. We get the license for the facility or the organization and the facility. Man, for example, etc. Later, there are many ways of doing it without necessarily having the specific provider through a training and credentialing. That would be decentralized, not a big center.
Yeah.
I'm just thinking in our former organization, we privilege physicians in their credentialing to practice. Now, that doesn't apply to clinics and online things like that, but you're essentially doing the same thing.
Yeah, we have an
Through privilege.
Through privilege and credentialing, that will be our.
So for folks on the phone, just so I want to make sure you're tracking the conversation. The question is, do we ever envision clinicians who want to do telemedicine? Do they need to be certified? And that would be the role of a technical assistance center. I'm not sure that we totally tackle that today. Maybe we table that for future. I think it's a great question. And just to your point, we do have a process at the University of Washington where we have sign off on them. So, any doctor can't just go ahead and do this on their own, because there's a real chance that they're going to be outside the guidelines and regulations. We don't want rogue providers. So, yeah, Dave.
I just wanted to do one thing. I've done a lot of work in Syria. I've actually helped develop some of the ATA guidelines. And I'm not aware of any state in the U.S. that has a certification program that's part of a state. And could be one, which is something recent, just FYI. It might make some sense to kind of research that to be sure. But I do know lots of competency kind of groups that look at the core competencies for doing something. Training programs that are out there. There's these models for it. I don't know many that are mandated. The ethical guidelines of psychiatrists or psychologists, they do specify things about being competent in the area of practice, and some telemedicine falls under that. But there's not an existing certification of it. It seems like
On some standard practice of medicine would see where this issue comes. Honestly, if some practitioners studying it for possibly around the country or something, I don't have a clue what these guys know.
I don't think I know you.
The ARNPs and the practitioners who prescribe, and they're also, for instance, there's one gentleman I know that the psychiatric ARNP who's providing telemedicine counseling in the corrections facilities in Washington State. So there's a group of people out there who are already practicing telemedicine, and I would suggest if you're going to move towards certification and whatnot, that maybe we have some kind of a group where you actually bring in practitioners, psychologists, psychiatrists, ARNPs, physicians, all those folks that are potentially doing it, if you're going to move towards certification. Right now, they're actually practicing.
I wonder if we could tie this into some of the other discussions earlier on, was looking at the licensing requirements for, if you're in Michigan, you're seeing visits in Washington. Right now they have the same licensure, but do you look at, if you're already providing clinical services in Washington State, you want to branch to see those same patients via telemedicine, you can do that. But if you're in Michigan, then you need to do some sort of certification or something. But I am concerned about the people and the providers in Washington, and it being an artificial barrier. It's just one more checkbox that, I got to renew this every 2 years, and I have other things I have to keep update.
Yeah, we could do it as a CME. I'm wondering if I can call on Jeff Jones, since he's a small practice in Newport. Jeff, if you're on the line,
I am.
Would having some kind of a certification to do telemedicine, would that be like an undue burden? Like a 4 or 5 hour class, would you do it, or was just too much of a barrier? Without knowing.
Good question. I guess it would depend upon the community need for telemedicine. I guess for instance, Suboxone certification takes 8 hours, but we have a big community need, and so a few of us got that done. So it would be a little bit of a barrier, but you could do it depending on how motivated you were to use this service. Does that make sense?
Yeah, it does. And I think that's a great analogy, the Suboxone training. Ricardo?
I would suggest that, I think I expressed one of the first meetings that we would like to see staying away, this committee, this collaborative staying away from the licensure and certification. We're not talking about necessarily conflict. The clinician that will be providing telemedicine, they can also do the same thing with one-on-one. There's no difference in the provision of care. The provision of care is the same. Standards are already guaranteed. Licensure by board membership and their own specialties. So I don't think that this collaborative is in the, I would say, that qualification is not a purview of this collaborative, in my view. This should be handled as a process issue rather than a credentialing or like Suboxone training. Suboxone training is, I don't know how to use a medication. I need that.
Right.
And I need a certification. This is the provision of care which I was trained already on, but using a different format. I would actually equate it to the teaching, which is in health centers, community health centers. Teaching is an incredibly important tool that we use to enhance primary care providers, etc. So by contract, and when we credential and privilege providers, we set the expectation. You're signing a contract that will allow you to do a percentage of your work, teaching, role modeling, mentoring, supervision, and so forth. So that teaching happens. They don't need it specifically. It's just a process. In the privileging, the credentialing, the process is how we handle that.
Yeah, I have no problem, and in my thinking, with medical doctors, DOs, psychiatrists, when you hit that top level, ARNPs, etc. But when you get down into some of what some of the states are talking about is healthcare, home healthcare worker type things. You're talking about people that we haven't figured out even, what their credentials are to do mental health. When you're talking about people, they're talking in the state under this innovation grant of peer-to-peer, paying peer-to-peer. There's no qualifications. There's no nothing. And so, if they bill, will they be paid? If we're doing parity, it's my concern. If they even treat, what are their trainings? And if they're going to do it through here, they have to have that. That's my thought. It's not about the MDs. It's not about the DOs. It's not about that level. It's that next level down. And in some of the states, by this report, I'm seeing, like home services.
Yeah.
There's a different level of concern there, but I don't think it's something that we should get stuck on today, but I think we should.
Do you want to tee that up for next time, maybe? I mean, I think this is a good question. Yeah, we'll tee it up. Since we have Micah Matthews from MQAC on the phone, Micah, do you have any comments on the certification for telemedicine?
Yeah, I'll just offer a couple things. Number one, I will start off by saying I perhaps didn't hear everything everyone said on the beginning of the conversation, but the gentleman that preceded Senator Becker and also Senator Becker's comments, I would have to echo support on, simply because you don't want to create a barrier, number one, to those that probably already have the training. And since this collaborative seems to adopt the standard that care delivered through telemedicine is medical care or nursing care or whatever you want to call it, it's the same. It's just a different delivery model. I think that's a good line to keep with. The only thing I would add is you might want to delineate the concept of direct-to-consumer delivery versus peer-to-peer billing, that sort of thing. I found it helpful to keep those two concepts separated, just because it really clarifies the conversation with respect to how you need to craft entry vehicles and whatnot.
Thank you very much, Micah. Yeah, Danny.
The other concern I have is for those of us who have health systems that are in multiple states. We frequently import and export providers based on capacity. So we have licensing, we have credentialing, now we have one more barrier. It's cost, it's complexity, it's an incentive. So I'm really concerned.
No, well put. Thank you. I think this can be a great discussion for next time. So I think we were looking at the FAQ, and maybe if I can ask Sheila just to, if you can go back and we can work together, add more Washington State specific issues. And then I think there's a question about licensure. We'll need to add that to both the clinicians, probably more relevant for clinicians. And,
only because as a patient, I expect my
exactly.
to be licensed.
Yeah.
Regardless of whatever medium service. So I'm not sure when to add that to the patient.
Yeah, maybe we'll keep that.
Yeah,
thank you. Okay. Well, great. Thank you, everyone, for your comments on the FAQs, and I'll send those out for further comment. We have about 45 more minutes, and I have some special guests who made the trip down to Olympia. I want to make sure we give them ample time. So I want to introduce Dr. Mia Shim, who is a hospitalist at Virginia Mason, works with Julie Sylvester there. Mia came up from the Southern California, LA County area where she was working on a project called eConsult. She's going to tell us about that. And then I also want to introduce Sally Nelly, who's the Executive Director for Project Access. I'm going to tee up there. After that, then Chris is going to talk a little bit about what they've been doing on the Group Health Kaiser. So is it this one? Yeah, it's this one here. So if you, Mia, maybe I can introduce you. Have you come up here? And
welcome.
You're welcome. Great. Okay, I'm just swap.
Good afternoon. My name is Mia Shim, and thank you for your invitation. And just wanted to let you know that first, the incentive for me to start studying telemedicine was about 10 years ago when I was trying to find innovative ways to help the most severely limited resource area of the world, and that was sub-Saharan Africa for me. So with the NIH in U.S. And through their funding, I started studying SOAR and Forward telemedicine. And I realized the benefits were quite strong even then on, and foresaw a future in this and continued to work on this. And in LA County, they were launching eConsult in 2012, and I was part of the launching group. So I like to share that story with you today. I have no financial or relationship disclosure. Objectives that I have today is to stress the urgency of improving the state of current healthcare system that we have, and discuss why telehealth solutions might be effective tools in healthcare delivery and capacity building. I'd like to share an example of a large-scale eConsult implementation. I don't know any eConsult implementation larger than Los Angeles County to date, so I like to share that and my experience there with you, as well as some cost-effectiveness data, in addition to some of the thoughts that I have for looking forward into future opportunities. So I'd like to start with the case, Jim. He's a 32-year-old hardworking father of two with a chronic inflammatory bowel disease that has him susceptible to persistent bloody diarrhea, and that's called ulcerative colitis. And unfortunately, he ends up in the emergency room, and from there, he gets some medications and sent to the primary care doctor for follow-up. He's initially somewhat controlled with medications, but he needed some gastroenterology help, and so the PCP sends a referral to the gastroenterology specialist. 6 months pass, and he has another 2 ulcerative colitis flare, and he visits ER twice again, but he still hasn't seen the specialist. So unfortunately, this is a very common problem, and Jim is a real patient. So we see this access to specialty care problem throughout safety net population, and I'm sure it happens with throughout the country. In Los Angeles County, for example, this was 2011, before the eConsult was launched. We saw the long wait time to see a specialist, anywhere between 3 to 7 months, depending on specialty. So how do we improve health in a resource-limited, fragmented healthcare system with long wait time for specialty care services, lack of coordinated care, high no-show rates to specialty care clinics, practice variations among different clinicians, and low patient and provider satisfaction? And the challenge is compounded. I know you can't see the numbers very well there, but it is a projected physician shortage. So by 2025, that's only 8 years from now, we are anticipating about 62,000 to 95,000 range of physician shortage. And as our population ages, there's greater amount of chronic diseases to manage, but we don't have enough workforce. And this is only depicting the physician shortage, not other healthcare staff, and we anticipate nursing shortage as well as other healthcare providers. So we have a challenge ahead of us. So in this, with this limitation, can we leverage telehealth in order to offset the capacity issues? I know there was a definition, that discussion that was going on. I see telehealth as a broad term that encompasses those 4 major modalities. Live interactive video, Store and Forward, which I will be talking about in eConsult, is included in this. A remote monitoring, like a patient needs a blood pressure monitoring, glucose monitoring, that doesn't really require a physician. Project Echo, I'm sure John is very involved with. And the data after data, study after study shows a number of advantages using telehealth. So just to briefly touch on live interactive versus Store and Forward. Again, telemedicine to me, when I was first studying, the definition is what ATA kind of talks about, it's a broad term that simply means the delivery of medicine across distance using information communication technology. That's what the broad term means. Telehealth, I think, is broader than telemedicine. It includes the remote monitoring, like we talked about, and that doesn't really involve the physicians all the time, so you're encompassing a broader picture. And live interactive video, a lot of people who are not as familiar with telehealth and telemedicine associate telemedicine, and they use interchangeably with live interactive video, but really I think it's a subcategory of telemedicine, and Store and Forward is another category of it. So live interactive video is a synchronous, real-time. You are simulating a patient's visit through the video, so patient and the consultant, or patient or the physician, are interacting through the video way. And this requires higher bandwidth because it uses electronic video equipment, which could be more costly. Store and Forward, which I want to focus on today, is asynchronous, logistically straightforward, and I will show you an example in the next slide. It doesn't require as much bandwidth, and the equipment cost could be lower. So this is an example how you would envision a patient visit. So a patient is visiting the primary care provider in clinic with a concerning rash, and the PCP wants to send this patient to a dermatologist, but instead they have eConsult, let's say, and so they take an image of this skin lesion and then types a brief history of this patient, and submits it via e-consult through an internet platform. And then the dermatologist on the other end, at any time, at any place, accesses this information, reviews the image and reviews the history, and sends back the reply with recommendations. Patients are taken care of at the PCP, so the patient can come in at 8 in the morning, see the primary care provider, and then the dermatologist will access, because they have time in the afternoon, and sends a recommendation 3 p.m. They don't need to, the dermatologist does not need to communicate or see the patient. They have enough information. So you can imagine there could be, it's much easier to use. You can generate a lot of volume patient visits. In Los Angeles County, they have an app on the smartphone, so the specialist can be waiting for espresso and be accessing e-consult and providing recommendation if it's simple enough. Okay. So e-consult is HIPAA secure, web-based clinical conversation portal between PCP and specialists. In Los Angeles County Department of Health Services, they launched this system in 2012, and by 2015, these are the numbers I like to share with you. Is 150 primary care sites. There are over 3,800 primary care providers who are actually participating in e-consult. Over 60 specialists are on board as of 2015, and that's pretty much covering all specialties. Over 13,000 e-consult requests are submitted each month, and that's very high volume.
Ask a quick question.
Yes.
Roughly how big a patient population is that across?
So I can give you, LA County has 10 million people. That's higher than Washington State and the entire Washington State. And then, LA County safety net population is quite big too. And they're also including the community partners. So the LA County system takes care of about 700,000 patients, but that's not including the community partners. Okay. And that extension, I'm not sure, but you can imagine. Yeah, a couple million at least. Yeah. So the underlying principles behind why we wanted to launch e-consult is that because of all the challenges that I talked about in the beginning, we wanted to make this system a little better, and that's to provide responsiveness so we can address the patient care issues more quickly, to create collaboration among the clinicians. The power of dialogue is something that we really needed. The equity, regardless of the patient's ability to pay, we wanted to be able to provide the great care for everyone. And also patient care satisfaction, that was important. These 4 principles lay the foundation for effective practice in the real world. The implementation of e-consult is more intricate, but I like to share with you the 3 main components. The work group is a specialty primary care work group that was formed for each specialty practice, and I will discuss in a little more detail next slide. And we needed a e-consult technology platform to deliver the specialty care services. And third component is a central referral unit where the staff are available to facilitate the appointments when the patients are required to see a specialist in person. So I'll talk about that in a moment as well. So specialty primary care work group was formed for each specialty, and this work group consisted of selected specialists across the LA County Department of Health Services participating facilities and selective primary care providers. And they were charged with coming up with expected practices, and they came up with that term in LA County, which is essentially the best clinical practice guidelines with evidence-based and the experience from the specialists, and they came up with guidelines based on the regional resources. And so that allowed for those who are using those guidelines can follow and reduce the practice variation. And then this also allowed for collaboration across facilities and disciplines, so they're communicating with each other. If there are any troubleshooting that's needed in consult, this will be the group to discuss it and implement any strategies. The central referral unit is just as critical, and so the patient-centered specialty scheduling, and when patients were identified through eConsult that they needed a face-to-face visit, they will be automatically sent, their information will be sent to central referral unit, and the staff from there actively calls the patient and make the appointment. And so this improves the patient experience, and it had quick turnaround time, reduced variation in process, it lowered no-show rate, and this translated to effective work, not just efficient work. So one of the results of the study is that eConsult utilization, so we accumulated, this is 2015 data, about 240,000 submitted eConsult over 3 years. 61% of that ended up still seeing the specialist face-to-face. And then 15% was the needs were addressed by just communicating through eConsult. 13% is still in dialogue, so that piece can go anywhere in that pie. And 7%, some of the patients eConsult that needed direct procedures instead of seeing a clinician, and we identified those as well. So the patient comes in with rectal bleed, and instead of going to a GI specialist, they'll be sent for a colonoscopy. And then 2% is administrative close for various reasons. 3%, there was a specialty change, so the triage decision if a patient was referred to orthopedic spine, but they decided it's better to send the patient for neurosurgery, that change could be made. And that happens just because the doctors are talking to each other. And 61%, I just want to also mention that within that 61%, we were able to better triage the patient based on their medical acuity. So if the patient appeared to be more sick, then they will get closer appointments, like 1 to 2 weeks with a specialty of choice. And then if the patient had a chronic, more stable disease, and their appointment could be pushed back to 2 to 3 months. So the medical triage decisions happened much more effectively as well. So eConsult response time is, again, very significant. RPS, the light blue bar that you see on the rightmost side, is an old system that required about 6 months or so to get an appointment with a specialist. But once we launched the eConsult, when the primary care provider submits a eConsult request, the first time they'll get a response from a specialist took about 2.7 days on average. And then they will have a dialogue back and forth, and it will close by 9.5 days on average. And then if the patient really needed to see a specialist despite the interaction, just like the 61% of that pie chart, it will take about a little less than 2 months to see a specialist. So that's a drastic improvement from the old system. And this is a safety net population, so with the limited resources, limited workforce, so you have to take that into consideration in terms of the days to intervention. Yes.
Just ask a question about the 61% that still had to go see the doctor. So that e-consult that happened prior to that, was there any value that that provided to that visit, or was it just kind of an added step that, in essence, it didn't replace any convenience or care in that place, but essentially you ended up with a visit plus an e-consult?
So previous method would have been using another system, like it was an online RPS system. You needed to go through that process to even get a referral. So e-consult did not add any extra step. You're adding a patient's history, a pertinent history, just to get a consult anyways. And so then the triage decision would be made based on what the specialist is reading from the other side, and say, well, I can answer this without having to see the patient, or I need to see the patient, then they get the appointment right away. So it is not an added step, it's just a replacement of the old step, and you can actually effectively communicate better.
Was there any data sets that helped you understand if, on the reverse side, if it actually reduced the number of follow-up consult visits with that specialist? So for instance, before that step existed, did it take 3 in-person visits with the GI specialist to resolve their issue versus, well, now at least I have enough information so I can order the MRI or a colonoscopy or whatever it is that they needed, so they had the result for that first visit?
Yeah,
Is
I
there
don't
a way
know
to
that.
measure that?
I can tell you this. In LA County, no, we didn't generate that result. But I have studied telemedicine for over 10 years. And one of my first publication is that this was a sub-Saharan Africa. But it does show improved education in the primary care providers, because they're learning from the dialogue that's happening from the specialists. Okay, and so the first point on the impact of the e-consult in this slide kind of has a transition to your thought process here. So the one of the things that that we did with implementation is that the primary care provider and the specialists are geographically linked. So they build relationships, collaboration, and accountability. And during this process, like we just talked about, they are learning from each other's method. And so if the patient comes in with, say, GI bleed, they know what the specialist is going to say. Over time, they know what to do in terms of diagnostic workup, even before consulting. So they're learning as you go. And from my previous experience and publications with primary care doctor learning from the specialist, they jumped drastically in a matter of number of referrals. And that study showed there was a 13% concordance. This was in Africa. And then by about 9 to 12 referrals, the concordance was 50% from primary care and specialists in terms of diagnostic accuracy. So that's what I saw, and it didn't really need to repeat itself in Los Angeles County because I know the benefits are pretty strong. So those are some of the benefits that we saw in the PCP specialists. The timely response, again, is critical in patient care, and that was delivered. And also, when you do see a patient face-to-face, you're improving the effectiveness because you're having that dialogue. And also to address your earlier question about, is this wasteful? No, it's actually not. Even if the patient is seen by a specialist face-to-face, because you had the initial dialogue, they may have suggested, let's get an x-ray first before sending the patient with me. Then they'll have more information to see that patient, and that first appointment is much more effective. And so that's what's going on. And then patients, importantly, are taken care of in a familiar and culturally appropriate patient-centered medical home instead of navigating all these different places. And this is cost-effective from societal perspective, and we did not also do cost-effective analysis formally in Los Angeles County, but I like to share with you the Ontario data in Canada. They had a smaller set of e-consults, 3,500, conducted over a period of a year between 2014 and 2015. And they looked at total cost versus total savings. And I know the screen is a little cut off, but the net savings they saw was about $40,000. And that is about $11 per e-consult. And as the patients benefited from avoiding the travel time, the lost wages and productivity, and those are the essentially the cost effectiveness from societal perspective. So, and I also want to kind of broaden the information out a little more than just the e-consult, just because the data, you know, one institution after another is showing pretty strong, remarkable cost savings and improved outcomes by delivering telehealth solutions. One of the pioneers of telehealth in the United States is Veterans Health Administration. They started using telehealth actively in 1990, and they have a lot of data to share. So in 2012, they saw about $6,500 per patient who are using telehealth per year, and that translates to about $1 billion system-wide within the VA. And a lot of benefits were seen by using telehealth and reduced hospitalization for various health illnesses, as you see there. And Mercy Virtual Care Center in St. Louis is relatively new. They launched in 2015, but they're already seeing a significant decline in inpatient length of stay mortality, also creating significant savings. And nursing homes alike, and Medicare is the beneficiary really. Nursing homes are saving money because they're not sending the patient back to the hospital for care as much as this, so there's a reduced hospital admission. Okay. So Medicare should take that into account when they consider payment model.
Excuse me. So the information that you just set up, was that based on the e-consult or telehealth in general?
Telehealth in general. So I kind of broadened out to telehealth just to send you the message that e-consult has its very strong point, but telehealth overall has a lot of benefits to consider.
So may I ask a question? So when I'm looking at the decrease of 40% for mental health, you know, when we have, and I'm looking at the VA and some of the things that have occurred with the VA, it kind of makes you question some of this, okay? And when I'm looking at a 40% reduction for mental health, is that because the patients, what were the outcomes for those patients? Did they actually get to see all the patients that needed to be seen and treated this way, or?
So I can tell you not just from the VA, so I don't know the breakdown of the data from the VA, but I can tell you from my experience learning about telepsychiatry. So in mental health, especially behavioral health, it's very significant, the benefits they see through telemedicine is that when they're able to speak with the patient, either over the phone or video, patients are not kind of reluctant when their mental state is poor to want to go out to see their clinician. So it's easier to pick up the phone. It's easier to just stay home and talk to the clinician. And they actually saw improved, decreased no-show rates, and patients who are going through a telemedicine way in order to address a mental health issue. And that's been studied in multiple different studies, not just VA. So I'm not exactly sure of the actual number. I'm just getting it from the reports. But what I'm trying to say is that mental health improvement is real in a real world, and not just VA, but throughout. So, and there is a reason I think that makes sense to me. So now that I've given you a lot of results and data, in terms of how telehealth could be very beneficial. So if telehealth can improve access and delivery, could telehealth expansion cost more because now utilization will go up, right? And this is a financial and policy question that we have to be mindful of. And one of the data that was one of the studies that was conducted in California shows otherwise. So these bars show that the follow-up visits after a patient undergoes telehealth versus a physician office versus the ER. So the first red bar is 6% follow-up visits are required after a telehealth visit. And when a patient visits a physician in the office, their follow-up rate is 13%. And when they go to an emergency room, their follow-up visit is 20%. So this suggests that by employing telehealth, and looking at financial options, telehealth could be a less expensive strategy.
Do you know were the conditions similar, all three of those?
Yes, that's the condition. Yes, the health conditions, it was pretty much similar, and that's what they looked at, just to make sure it's a comparable condition.
Sore throat, all three.
That's right,
Okay.
Exactly. Okay. Thank you for mentioning. I was going to mention that. So let's follow up with Jim. So armed with eConsult, the primary care provider submits an eConsult and receives the necessary specialty expertise within days. And the appropriate recommendation to adjust the therapy, as well as clear guidance what the next step and next diagnostic step is provided to the primary care provider, and the PCP contacts Jim and is taken care of. So most important thing is that our patient Jim is appropriately taken care of under a patient-centered setting. So, and he doesn't have to miss a day of work, and he doesn't have to take 3 buses to get across the town, and he gets to stay within the patient-centered medical home without going through a complicated registration process of navigating the specialty care clinic that he's not familiar with. Okay. And this is one of the quotes from our community partner medical director, eConsult. Okay, so looking ahead, we've seen a lot of benefits of telehealth, and it's going to be instrumental. Like, we are developing the policy, payment models, and so forth, but this is going to be a big part of our future. And it does play, and it is very much in line with the value-based payment model. So telemedicine parity law in Washington State, it does, from what I read, the reimbursement to ASTOR-informed modality is there, and it starts this year. So, and the originating sites where the patients are located, this could be extremely beneficial. And again, a lot of insurance companies and other folks might be considering, well, each and every account we have to pay, but really, I hope that I showed you that what the benefits are going to be society-wise, in the hospital, the system, even the insurance company, Medicare, Medicaid, they're all going to benefit from if this is implemented well, and patients are taken care of in a timely manner. Okay? So, but I also want to address, before I close, that as a physician, I do work in frontline and see my patients every day, try to provide the best care possible to our patients, regardless their ability to pay. But I also see my physician colleagues and specialists struggling with the patient volume that's increasing every day. So one of the obstacles we need to consider is that, yes, telehealth is no doubt going to be a solution that will increase the healthcare capacity. But at the same time, it's going to add work burden to our physician colleagues who's already stretched. And with the physician shortage and nursing shortage, we're going to face some obstacles there and resistance. So does it make sense to incentivize them so that we can modernize our payment model? And I think that's a well worth that discussion. And I think they might be more intrigued to do that. They need a time and incentive in order to carry out this work. And I know it can be done. It has been done in a large scale in other parts of the country. It can be done in Washington State. Okay. So telehealth solutions align with Triple Aim to improve patient care experience, improve population health while reducing cost. Okay. Wise use of technology can deliver cost-effective, timely, and appropriate healthcare to our patients. And I want to stress the wise use of technology because some of the best systems I've seen is not complicated. It's relatively simple, relatively inexpensive. What you need is the right people to do the right work. Okay, they need to have the right skills and understanding and how to carry out the implementation. So as we just discussed, payment model is a very important process. And the specialists or people who are delivering the telehealth and the care should be appropriately compensated because this is going to be one of the obstacles we have to face. And ultimately, more important than technology, the people who drive innovation and collaboration, and we all need to work together in order to move forward. And I'd like to thank Paul Gibney and Hallie who are showing tremendous leadership in order to move the e-consult forward in LA County. And please feel free to send me any questions.
Is it possible to get a copy of your slides?
Yeah, I actually sent it to you.
Yeah, certainly, we'll send those out.
Okay,
Yeah.
it would help me in my negotiating period.
Great, yeah. Good. So maybe if I can have Sally come up and speak. And Sally, I want to make sure that you explain what Project Access is for everyone.
Okay, I can do that. Project Access Northwest is the glue that makes a lot of safety net patients access to specialty care services work for them. We're an 11-year-old nonprofit, initially in Kane County. We actually serve Dr. Henry and his patients often, and we're now in Kitsap. She kind of described us. When folks get their care in a safety net in one of the community health centers and they need to see a specialist, there's not a similar system set up the way the FQHCs are set up. So we have become that hub for those 3 counties. And so my job is always to try to figure out what's going to make it work better for the patients, what's going to make it work better for specialists. And I came across the e-consult concept probably 1.5 years, 2 years ago because it seemed so brilliant and such a next step to me. So the low-income, uninsured, and Medicaid are kind of our peeps. You know, we're the cheerleader for them. We make sure that they actually land where they're supposed to land. And we have learned in the 11 years I've been doing this that specialists want to do the right thing, but you got to make it easy for them, and you got to not overload them, and the demand is too high. They want to help, they want to use their skills, they want to make it invisible and easy in their practice. And they want some of the challenges of the safety net patients kind of mitigated. They are challenging patients, they have a high no-show rate. How can we make it easy for them? So our care coordination makes it easy for them, and we have a less than 5% no-show rate that I'm really proud of, and that's why specialists like us. Community health centers like us because their patients get the care that they may not get otherwise. Patients like us because they think we're carrying them in these velvet gloves from place to place when we're really doing it to keep the specialist happy. You know, it's like we got to keep everybody happy all the time because that way everybody wins. So part of what we really like about eConsult is it's this huge advantage to every single part of the system. You know, the specialists get to provide that advice and consultation through the store and forward methodology, and then they get to practice at the highest level of their practice when they actually see a patient, instead of doing what could be done in primary care. Primary care could ask a few questions. So they're happier with that. Primary care gets an expanded specialty, expanded practice, and as Mia said so eloquently, their skill set rises. They get to have a bigger practice. They learn. They're constantly engaged. They get to take care of the whole family in a better way, which is the medical home model that is so important to all of us. The insurer actually gets more timeliness for the patients that are being served, which leads to enrollee satisfaction, which leads to them staying with the same insurer longer, and they get to avoid the facility fees. So that's a win for them. And the patient gets to stay in primary care where the practice knows them, where it's convenient for them, where, as Mia said, the patient doesn't have to take the same time off of work to get the care that they need. So I'm going to take us back to Jim, that we've seen a couple different times today, and now I'm going to move him to a rural part of the state where you mentioned a couple docs and a couple PAs within 20 miles. One doctor, two PAs, 20 miles. So he's no longer taking a couple buses to get to care. He's taking a half or 2/3 or 3/4 of a day off of work to get to care, driving on roads he or she may not be as familiar with. And his doc doesn't necessarily know what's going to happen except through the chart notes. So the primary practice doc gets to continue to provide the care kind of to the whole family and to the whole patient when they have the advice and consultation. One of the things that I learned early on in Project Access that kind of surprised me, and I've been in healthcare for about 25 years, and when I started at Group Health actually, one of the things that I often saw happening is the family practice docs that were doing rounds would kind of hang in hallways to catch a specialist as he or she came out of a room to ask for advice. This formalizes in digital or in electronics that same kind of stuff that family practice used to do naturally. They get that advice and consultation. They don't have to hang out in the hallway because they're not doing rounds anymore. And family practice docs have missed that opportunity to grow their skill set and grow relationships with specialists by being able to get the advice they need to really own their patients. So I'm just the cheerleader, I guess. That's kind of what I have to say about that. And I think it's a fabulous idea, and I think it would save the state a lot of money. It would also improve satisfaction at the clinician level, and it would really, really work for the patient. That's the part that I want to hit hard.
Thank you.
Emily, we're right at 3 o'clock, so I know there are going to be questions about payment, and Chris has also been doing this at Group Health. I'm wondering if maybe we could pick up this conversation at our next meeting. I'll just say we've been doing this at the University of Washington for 3 specialties since July, and the PCBs love it. It's improved our access already by 30%, so our wait time has gone down quite a bit. We've picked up 5 cancers, so 2 skin cancers and 3 hematologic malignancies. So I think that's pretty significant. I mean, our dermatology wait is over 6 months, like Mia said, and boy, I would hate to have that skin cancer festering for 6 months. So it's really made a big difference in our workflow. But maybe what we can do is just wrap up. I want to do some housekeeping. The first thing is our next meeting is scheduled at Molina. So Molina is kindly hosting us up in Bothell on March 9th, which is a Thursday. And Priscilla, can you remind me the time on March 9th?
From 9 until 11 a.m.
So 9-11 a.m. They have a very nice room.
Sorry.
Can you take notes and send us? We'll be on.
Yeah, take notes. And of course, we'll be on by phone and video.
Do you want me to make it later because it is during the rush hour?
If people feel strongly, I think we had an 8 to 12 window. It was just that the window that they had up for us. So I think we could do 10 to 12. If people really feel strongly, we could push it from 10 to 12.
I can also.
Julie, I hear you.
I'm just thinking from I do that drive probably once a week.
Yeah.
And it takes 2 hours to
Just that 4 or 5.
drive what normally would take 45 minutes.
I see.
So,
So 10 o'clock would be better.
so 10 would probably be.
Okay. So stay tuned. Email. The next week we will try to get to 10 to 12. Dr. Senator Becker.
Not Dr. Irving. I'm wondering if we can have the collaborative members, if I can get a photographer out, and we could go on the floor and get a picture of
Great.
all of us.
Yeah.
Okay.
Sure.
Okay. I'll go back and do the rest.
All right. Well, those folks who joined on the phone, I want to say we're going to wrap up. It's 3 o'clock. You didn't hear that, March 9th at Molina. So thanks, everyone.